Hi, I'm Brian Catterley from the Hendersonville Rural Family Medicine Residency Program. You're watching The Black Bag. This playlist we're going to be performing a thoracentesis with Dr. Gail Clary, pulmonologist here in Hendersonville and one of the 50 best doctors in America, according to Forbes magazine. There are a lot of videos out there about thoracentesis, but not a whole lot where you get to see it done in a first-person point of view. So I hope you enjoy it.
So we're going to do a thoracentesis. We're going to need a thoracentesis kit. We need a vacuum bottle to put the fluid in. We need my gloves. We need scrubby things. We need a red top tube. That's purple. We actually don't need a red top. It'll be in the kit, but that's okay. Some kits don't have them. You need a purple top tube. You need a blood gas syringe for your pH, and we'll get a cup of ice. So the most important thing is to make sure the patient is comfortable and safe. Okay, so we positioned her properly. Now, if we didn't know which side we were tapping, we could easily figure that out. And on inspection, we already see we've got quite a bit of kyphosis here to deal with, so that changes your anatomy a bit. But she's thin, and this should be easy to do on a regular physical exam. So part of your exam for, okay, all right. A chest exam is inspection. She's thin, she's kyphotic. Percussion, so we're going to percuss over here. It's pretty hyper-resonant here, and that's probably her diaphragm and her liver there because she's so kyphotic. Over here, I don't know if you're going to be able to hear this, but so there's dullness to percussion here. That's hyper-resonant. So I know the fluid is there, and there, and there, but when you get down here, and I'm sorry, my fingers are cold. And now here's the bottom of her rib cage. And what lives here? The spleen lives here, the liver lives here. So when you're going to tap someone to get fluid off, you want to try to go as low as you can so that you get all of it, but you don't want to go so low that you're getting into other things. Based on her x-ray, she has fluid to about here. Based on my exam, she has dullness to percussion here. And when I listened yesterday, she had diminished breath sounds from about her scapula down. So what I'm going to do is I'm going to go here to try to get as much of it off as I can, recognizing that since she's kyphotic, her diaphragm is shifted, and that means her diaphragm is up higher and her spleen is here. But if you watch her breathe, take a big breath. Excellent. In and out. Yeah. I'm not even sure that diaphragm works. So now we're going to open our kit, and we're going to get the things that we need ready. And for me, my workspace is on the bed, usually just because that's the way I learned to do it. Okay. I usually put the blood gas over there, so we have our vacuum bottle. So the first most important thing is to make sure that she's properly positioned and she's comfortable. The morphine is a good idea for anticipatory pain, and it just takes the edge off. I think everybody in the hospital should have water on their oxygen, given that the ambient humidity in this place. Okay, so we have a trash can. So we've prepped her. I'm always keeping an idea of my landmarks. Now, if somebody were doing this with ultrasound, of course, they would have probably marked it and using a sterile ultrasound. But I can have an ultrasound everywhere. So this particular kit has a large needle with a sliding soft catheter. So you get the needle out of the chest, and all you have in the chest is a catheter. Rule of thumb is that you never do this inside the chest. I've had one episode of a colleague doing that here years ago, and the surgeon had to go and fish out the sheared off catheter. So you can do it here while we're looking at it, but you don't. Yes. So what I do is I get all my stuff ready to go, and so the next thing that we're going to do, my dear, is we're going to get that numbed up so we can draw this fluid out. Just like I talked about yesterday. You know, when you go to the dentist and you have to have dental work and they numb it up. So I know where my rib cage is. I'm at the bottom of it. I always put my hand there as my landmark. And then what I've done is I've picked to go about 4 inner spaces up, recognizing that I've percussed dullness to here. So I'm in my safe zone. I know I'm above the diaphragm, and therefore I'm above the spleen, and I'm going to go over about here. So we're going to fill, and I probably should have put my drape a little bit farther over. So we're going to go right here above the rib. You always go above the rib because the neurovascular bundle, of course, is under. So there's the top of the rib. And now I'm going to look at her positioning, because you want to be going straight in. Straight in is not straight here because she is leaning and she's kyphotic. The rule of thumb is you always aspirate, of course, before you inject. This is a tiny needle, so this gets us started. And even though she's a tiny person, so I can get it out now. I put it on so tight I can't get it. Okay, I'm going to have to take it out. Okay. What I usually do with that needle is I actually leave it in, because as you can see it's a 25 gauge and it's short, so you're not going to get into the pleural space on most people. I always impale my needle out of the way. Try to keep all my sharps together in one place. And while we're giving that a second to take effect, then I get my other tubes ready.
Take a deep breath, okay? There you go.
The biggest mistake most of us make with procedures is we do them too fast, and we don't allow the medicine's time to work.
How are you feeling? Okay?
Okay, so we have a stopcock. We're going to connect the stopcock to the suction tubing. So we're ready to go with that. And then the more things you get ready ahead of time,
You're beautiful.
the easier everything is. I've got this ready to go. And now we're going to finish numbing her up. Okay. And she's not bleeding at all, so I don't even have a little blood blister to tell me, but this is where I was. Okay, we're going to finish numbing this up now, okay? So you may feel a little prick, but then the rest of it should just be sort of dull. All right, if I'm hurting you, though, I want you to tell me, because I want to stop.
All right.
And again, I'm going over the rib. And I'm aspirating as I go, looking at the angle that she is. I don't want to go like that. I don't want to go like that. I want to go like this, because that is going to get me the straightest shot into the pleural space. And there we are. Not very far. Because she's thin, it makes it very easy. So what I do when I get fluid is I actually come back right to that edge and try to get the rest of my lidocaine on the pleura. And then, because the only sensitive place is the pleura, right? Unless you are under the rib, getting that neurovascular bundle with an intercostal nerve, you aren't getting any pain fibers except on the pleura. So now I'm going to pull back enough that I'm not in the pleural space, because I don't want to lose my space now. And I'm going to get my fluid before I put my large needle in, because this is going to be sort of the best fluid I have, right? No blood in it. Okay. Now, actually, let's do this. Let's put our stopcock there. Put the stopcock on here. Then we're ready to go. Now, so we know where we're going. How are you doing? Did that hurt at all, darling?
No.
Excellent. You just told me exactly what I wanted to know, because I don't want to hurt you. Okay, so now I know where I'm going. Okay, so you should feel just a little bit of pressure. I only had to go this far in, so there's no need to to put this introducer in any farther. So we put it through the same place we've numbed up with the same angle. And she's sitting so nice and still for me.
I didn't hear.
She said, did they tell you you had tough skin?
Oh,
So I know I have fluid, so I know I'm in the pleural space. And now what I want to do is gently advance my catheter, trying to hold my needle in place because I don't want to advance the needle anymore, right? Yeah, we don't want that. All right, now we take that out and put a little gauze there. And now we've got one more syringe full of fluid. We're turning our stopcock off. We're going to use this for the other samples in a minute. And then we're going to connect this. And we're going to get all that fluid out, okay?
are you in there?
Oh, goodness, yes, ma'am. We are cooking with grease. Here we go. Now, so you have to watch this a little bit and make sure that you're getting your flow. You can tell she's got a little bit of respiratory variation. Take a deep breath. There we go. All right. So what we're going to do is we're going to try to pull this back until we get continuous flow.
You okay?
Okay, so now while we're waiting for the fluid to fill the little jug, we'll deal with these. So one of these we're going to send as a sterile to micro, and we're going to do AFB, bless you, AFB smears and cultures, and fungal smears and cultures, and gram stains and cultures, and that will be this tube. And then we're going to send this one, and we'll put that in the purple top for cell count differential. And then we're going to take this one for the chemistries. So it probably has just a little drop of blood in it, so it would falsely elevate your red count if I sent this one in that tube. Alright, so why are we going to send a cell count and differential? What we're trying to do is look to see if someone has an inflammatory effusion. We're looking to see if they have neutrophils. If it's neutrophil predominant, we think more about infection. If it's lymphocyte predominant, we think more about chronic infection, tuberculosis, lymphoma. If there are eosinophils in the pleural fluid, we think about someone who's had a pneumothorax and now they've re-expanded, or an eosinophilic lung condition like Churg-Strauss, or other allergic eosinophilic lung diseases. The longer fluid has been there, the stiffer the lung becomes, so it takes it longer to stretch out. So if you don't know how long someone's had an infusion, their lung may not actually stretch out during this period. Most people have enough elasticity in their lung that by the end of the procedure it will stretch out. The amount of fluid we take out is contingent on how the patient does. For a petite lady like her, we have only one bottle because I don't expect her to need more than that. I think she has about a liter in there based on her x-ray. You stop if someone's hurting. You stop if their vital signs change. You stop if you start getting red instead of yellow. And obviously the longer this goes, it's looking a little more blood tinged, right? So this is why you get your labs off of your first one. Okay? The reason people cough is as I'm making a negative pressure in the chest and I'm pulling the fluid out, then there's a void. So the J receptors, which are on the visceral pleura on top of the lung, get all excited because there's a pressure change, and it makes you cough to try to blow air into the lung to fill the space. If the lung doesn't fill the space, the body will actually pull fluid back in there to fill that space. So as far as the risk of the procedure, obviously there's a bleeding risk. You want to know if they're on aspirin, if they're on Xarelto. And oh, by the way, we stopped hers 2 days ago, which is why we waited to do this today. Aspirin, baby aspirin's okay. full dose aspirin is probably okay on somebody who's as easy as she is. Coumadin, liver disease. In my experience, people can easily be tapped, even with an INR up to 5 or 10, if they are technically easy. You can add an ultrasound to it, but this is such an easy procedure because she's thin. So you're watching to see how the patient's doing, if they're getting uncomfortable, because pulling that pressure, if the lung doesn't stretch out quickly, that's uncomfortable. Some people hurt from it. Some people are just uncomfortable. When they're coughing, that tells you you're getting close. So then you start looking at the rate at which your bottle is filling up. When it starts getting to a little dribble, then you start withdrawing your tube. And what I try to do is I try to drain people as dry as I can, as long as they're comfortable and their vital signs are okay. In someone her size, I would probably never drain more than 1 liter. The more you drain off, the higher your risk of hypotension, because you're shifting the whole intrathoracic space around, and that changes your preload. Okay. I always give people pre-meds because if I ever have to do this again, I want them to have had a good experience the first time. So the rule of thumb is that you probably never take off more than 2 liters at a time, but you can push it to 3 as long as they have good vital signs. What you don't want to do is you don't want to take off so much that then the lung is forced to re-expand quickly, because this is quick relative to the time it accumulates. And then cause re-expansion pulmonary edema. So your post-procedural risk or pain, bleeding, post-evacuated pneumothorax, or pneumothorax if you've nicked the pleura going in, and re-expansion pulmonary edema. So someone can actually become more hypoxic after you've pulled all the fluid off, because when the lung re-expands, you're improving ventilation. But if the perfusion also improves and there's a mismatch, then you can actually become more hypoxic. Yes. And you know what? We got the last drop. Okay, darling, I am done. Back to the fluids. On the chemistries, you want to get a glucose. Low glucoses make you think about malignancy, tuberculosis, rheumatoid arthritis. You want to get a blood gas with a pH. A low pH makes you think about infection, cancer, rheumatoid lung disease gives extraordinarily low pHs. You want to look at the fluid though. If that fluid had been green, then that would be rheumatoid arthritis. If that fluid had looked like milk, that's a chylous effusion, and then your differential diagnosis goes to thoracic duct ruptures and lymphoma primarily, or trauma. Now, for people who do ultrasound guided, and I've done that before with one of the PA students, is you get the pre and you see the big pocket of fluid on the ultrasound, you get the post and you actually see the lung at the edge. And there are people who would say that if you're doing ultrasound, you don't have to do that. I think that given the fact that people don't always know where they're going to be working, to me you should learn how to do it this way, and then if you get those extra luxuries of ultrasounds, then you go with that. So if you're looking at the light criteria, Brian, for exudate or transudate, there's lots of arguments over what makes a transudate or exudate, but basically an LDH and a protein, the higher the protein, the more likely you have an exudate. The higher the LDH, it's an exudate. Then you start down the differential diagnosis of is what makes a transudative effusion and what makes an exudative effusion. And I'm sure that there are lovely tables in your phone for that. But pH, if you're in a place where you can't get a lot of things, a pH, an LDH, a glucose, a protein, and a cell count. We always get an amylase simply because in malignant effusions you can have a high amylase. The other thing that will cause a high amylase in an effusion, of course, is esophageal rupture. And then we send a purple top to get our cell count and our differential. And we do all these afterwards because these aren't sterile, of course. Okay, so that's ready to go. We don't need the red top because this kit actually has the tubes. So then I am going to get rid of all my sharps. This is for cytology. This is our cell count and differential. We're going to have a sterile tube for micro, and we have another sterile tube for our chemistries. We're going to get an x-ray, and we're going to let you have breakfast.